Today I want to talk about atrial fibrillation treatment. Before doing it, I want to briefly talk about atrial fibrillation. Atrial fibrillation patients usually come to emergency rooms with palpitations, and we usually do ECG, and in the ECG we should see different RR interval distances and no visible P waves and different amplitudes of R waves. Atrial fibrillation might be caused by only one origin of excitation impulses, which is called focal, or it can be caused by multifocal impulses. In order to understand if it's multifocal or focal, we should see P waves in D2. So, what should we do if we have a patient with atrial fibrillation? We first need to check vitals. If the patient is hemodynamically unstable, we should do electrocardioversion, but it's very unusual because atrium contractions do not cause unstable hemodynamic conditions. And in hemodynamically stable patients, we should control ventricular rate first because it might cause ventricular tachycardia. So, for the control of ventricular rate, we use beta blockers, calcium channel blockers, which is non-dihydropyridine ones, verapamil and diltiazem, and digoxin. And we also give patients oral anticoagulants because patients might have thrombus. So, those thrombus are caused by spasmodic atrial contractions. So, atria cannot pump blood. It stays there, and stasis causes thrombus, and thrombus causes stroke. So, in order to prevent stroke, we give anticoagulants. And usually people are cured. And before discharge, we should check CHA2DS2-VASc score. What is CHA2DS2-VASc? C is for CHF, congestive heart failure, and H is for hypertension, and the first A, which is 2 points, is H greater than 75. D is for DM, S for stroke, and it is also 2 points. V is for vascular diseases, A is for age between 65 and 75, SC is for sex characteristics, and if the patient is female at birth, it gives patient 1 point. Then, if the points of the patient is greater than 2, we should give them oral anticoagulants continuously, because those patients might have those atrial fibrillations again in their lifetime. So, what kind of oral anticoagulants we usually use? First, we have warfarin. Warfarin inhibits vitamin K activity in the liver. So, it inhibits factor 2, 7, 9, and 10 synthesis, and also protein CS synthesis. While using warfarin, we should keep INR between 2 and 3, because if the INR is greater than 3, it might cause bleeding. So we also have dabigatran, which is a factor 2 inhibitor. It's contraindicated if the patient's GFR is less than 30. And we also have apixaban or other drugs that end with XA-ban. Those XA stands for 10A, activated 10. So 10 is the 10th factor. It's called strut factor. It's important right now, but you should know that apixaban also used as an oral anticoagulant, and it's also contraindicated if the GFR is less than 15. So let's go back to the patients which are not cured. So we usually consider cardioversion, and before doing it, we should first check if the patient has the atrial fibrillation for more than 48 hours or not, and risks of stroke. If the patient has the AFib for more than 48 hours and high risk of stroke, we usually do transesophageal echocardiography, TEE. And if we see a thrombus, we give oral anticoagulants for 3 weeks, and then we do TEE again. If you do not see thrombus again, we consider cardioversion. So, for cardioversion, we also divide patients into 2 categories. First one is patients with less than 65 years old. We do chemical cardioversion, which is sinus rhythm control, and To do that, we use class 3 and class 1C antiarrhythmics. In class 3 antiarrhythmics, we have amiodarone and sotalol. And as a side effects of those, amiodarone has side effects of it contains iodine and high levels of iodine. It disrupts liver function tests and thyroid function tests. So to see if the patient is using amiodarone correctly, you should see T3, T4, TSH, okay? And in a long use, it may cause pulmonary fibrosis and vision impairment. And sotalol, which is a beta blocker, it may cause QT prolongation. If the patient's QTc is more than 480, it increases the risk of torsade de pointes, and if the QTc is more than 500, you should stop medication. And for class 1C antiarrhythmics, we have propafenone and flecainide, and they may cause ventricular malfunction, so do not give patients with CHF. Okay, and for the patients which is more than 65 years old, we usually do electrocardioversion or ablation. Actually, we usually do electrocardioversion because they are usually multifocal and we cannot do ablation therapy for them. So we do electrocardioversion, and then we give them oral anticoagulants for 4 weeks. Then we check Chat's VASC score again, and if it's more than 2 again, we usually give oral anticoagulants continuously. Because, as I said, patients might have AF again in their lifetime. So thank you for listening.